Welcome. Uh, in this brief video, we're going to be continuing a discussion that's already come up in this course on medical ethics. And that's the question about how disabled people are treated within medicine. Now we've looked at broader questions about how the quality of life is sometimes evaluated for people with disabilities. And this particular brief discussion will center around practical questions about how certain policies surrounding COVID-19 interact with discrimination against disabled people. So in this, we're going to look at two pieces. These pieces were originally both published in the New York Times in 2020 when the pandemic was beginning. And they're going to offer us two opposing perspectives. So that's the plan. We're going to look at first a piece by Ari Neyman called I Will Not Apologize for My Needs, which was published in mid-late March 2020. And we'll then look at a response that was published by Joseph Finns, originally also in the New York Times, and then eventually in a book called The Ethics of Pandemics. So let's get into it. Neyman is concerned as a disabled person and as a person who advocates for people with disabilities. Neyman was very concerned at the start of the COVID-19 pandemic, the ways in which certain policies might impact people with disability. And this is because in hospitals, ICUs, and emergency rooms, a common policy will be to engage in what is sometimes referred to as triage, right? This is a situation where resources are limited and the needs of patients are great. And in these situations, we try to figure out which individuals have the best prognosis of recovery. And in these cases, if we have one patient with a good prognosis of recovery with treatment and another patient with a worse prognosis of recovery with the same treatment, the thought would be we would give the patient with the better prognosis the treatment in order to use resources most efficiently. That's the common policy, and that's a policy that Neyman is concerned about. Neyman has noted that in certain jurisdictions, and early on in the pandemic, there were situations where patients with severe intellectual disabilities, they were considered to be unlikely candidates for ventilator support. So the issue here seems to be a patient is considered to be a less viable candidate for resources and triage when they have something like an intellectual disability. And Neyman also gives evidence about a worry. Now, a tricky thing is that in his essay, he's not saying we have evidence that this is going to happen here in America, but he has said, among the disabled people who I work with and who I've talked to, they have expressed a worry that they might have their ventilators taken away from them and have those ventilators be given to another patient. So we might imagine a disabled person who uses a ventilator chronically, that is all the time, and it's just like part of how they stay alive in general. Some people have maybe worried that they would have their ventilators taken from them and given to an able-bodied person with a better prognosis. And Neyman has said, in some cases, people with disabilities, and especially people on ventilators, have simply decided not to go to the hospital because of that fear. So here's the proposal that Neyman lays out towards the end of his piece in the New York Times. Remember, his piece is called I Will Not Apologize for My Needs. This is what one of his disabled activist friends claimed, that I should not be sorry that it might take more resources to save my life. Naiman says, in order to really take seriously the needs of people with disabilities, he said that ventilators should be distributed on a first-come, first-served basis, rather than on the basis of ruthlessly efficient optimization. And here's the thing. Naiman is, in fact, willing to admit that by using a first-come, first-served rationing system instead of a prognosis-based system, we might actually save fewer lives in the course of the pandemic. But Naiman says that might just be what fairness and justice require. And sometimes fairness and justice will require that we save people in a fair way rather than an efficient way. So this is one perspective on how disability and COVID resource allocation might come into conversation with one another. Naiman is basically arguing that different policies should be adopted in order to protect disabled people. Now, Finns, on the other hand, also a healthcare policy expert, has argued that there is something mistaken about the proposal that Naiman makes. So first he discusses the kind of system that's being used in New York State. And he explains that the way that something like a ventilator would get allocated once they become scarce is a patient would be scored according to what is called the sequential organ failure assessment. You get a number for that. It's called your SOFA score. And what happens is patients, on the basis of their score, will be sorted into 4 groups. Right? We get blue. These are people who will not survive infection, even with maximal effort. We have green. These are people who are sick, but who will not need a ventilator. They will end up surviving even without that resource. So the suggestion here is that people grouped into blue and green, they don't need ventilators, but for very different reason. Blue because they will not survive even with one. Green because they will survive even without one. But then there's 2 further groups in between these two. There are people in the red group who are most likely to survive if given a ventilator. And there are people in the yellow group. So these are people who, like the people in the red group, would benefit from access to a ventilator, but they have a lower chance of the people in the red group of surviving. So in that way, they're between red and blue. They're not hopeless, but there is a chance that resources used on people in the yellow group might not be effectively used resources. And Finns' proposal is basically that if we use this system, we will make sure that we're not using ventilators for people in the blue and green groups, and red will get priority over yellow. Now there's a further question here. When we score people according to this metric and sort some people into the red group and some people into the yellow group, does this discriminate against people with disabilities? Finns suggests that this approach that uses a SOFA score is going to disentangle a person's physiological state from their disability. So in this way, he's going to say, look, it could be the case that there is somebody with a disability who, based on their overall physiological health, could fall into the red group, whereas somebody with a different situation, maybe no disability, but a certain extreme case of COVID, might fall into the yellow group. And in that case, it's totally possible for a person with a disability to get access to the ventilators that they need. Now, there is a further question here, because it might be that some disabilities that some people have might inherently lower their SOFA scores. But Finz's point that these things are disentangled is going to suggest that at least a person is not being directly scored in terms of where they're going to land in a triage on the basis of having a disability. Last thing that he notes is that patients who have ventilators in chronic use, that is, a person who has a ventilator all the time and all their life, he said that according to the New York policy, they would not have their ventilator taken away from them. But if this person fell ill and needed a more sophisticated, stronger ventilator that they're not usually using, then they would be considered one candidate for that ventilator among many. But a standard ventilator would not be taken away from the patient simply because somebody else might be able to better use it. So there is an exception to this strict efficiency-based model in that dimension. So we get two differing perspectives here. So I'm going to leave you with just a couple of questions to reflect on. First, which policy is ultimately more justifiable when it comes to distributing resources? Should we use something like the policy that Naiman advocates for, something like a first come, first served system? Or is a triage-based model where we use prognosis to determine who gets a resource one to use, something like the SOFA system that Finz outlines? And I guess we would ask a further question. Is there a way of evaluating a patient's chances of survival without discriminating on the basis of disability? Or is there discrimination on the basis of disability if, for instance, a condition like cystic fibrosis might predictably lead a person to score lower on the SOFA system? So I'll leave you those questions to reflect on for yourself. Thanks for listening in, and take care.